Good morning to one and all. And today, as part of the master class series on CA prostate, today we will be discussing the management issues with regards to CA prostate, which we had already discussed. The radical prostatectomy and radiotherapy we have already discussed. Last class we also discussed about the biochemical recurrences, what the exact definition of biochemical recurrences after radiotherapy and after radical prostatectomy. We talked about the astro definition, we talked about the Phoenix definition of biochemical recurrences. And today I thought maybe we can cover up a little about the various trials that were involved in evaluation, screening and treating CA prostate. So that is going to the next about 45 minutes or so we will discuss the various landmark trials in CA prostate. Why this is important to know about the various trials as far as CA prostate is concerned is because there was a time in the early 2000s or maybe late 1990s where the PSA was playing a very vital role in making a diagnosis of CA prostate as well as in treating those patients who were diagnosed to have malignancy of the prostate gland. Any patient, anybody and everybody above 45 or 50 years of age in the United States of America were being screened with serum PSA, and an early diagnosis of CA prostate was made those days. And that is the time when they started talking about stage migration. That is what was picked up very late in CA prostate was picked up very early. So that is the time when they started identifying all these patients with CA prostate. They were offering radical prostatectomy as a one-time definitive procedure. And in Journal of Urology, in the early 2000s Journal of Urology, if you take out of 30, 35, 40 articles which are published, almost 70 to 80% of them will be related to CA prostate and radical prostatectomy. So that is the time when CA prostate was a very, very hot topic, and every urologist, and that is the time when the robotic technology, laparoscopic and robotic technologies were flourishing as well. People started talking more and more about laparoscopic radical prostatectomy. Then the robotic technology came into vogue in the late 2000s, and then the papers on robotic radical prostatectomy were also very, very popular. And screening as a in the screening for CA prostate was also being widely encouraged. And then again, as you all know, there are always two schools of thought. We have an American school of thought, we have a European school of thought. The American school of thought being more aggressive approach, the Europeans always followed a more conservative or traditional mode of approach. The Americans always say that if you know that the patient has got malignancy, what is the point in hanging around with the patient, not doing anything at all? It is always better that you offer proper treatment, eradicate the particular malignancy. The European school of thought always takes various other variables into consideration. They will always say that is this particular procedure that you are offering to the patient really going to offer any significant benefit, or the morbidities related to the procedure that you are going to subject the patient to, is that going to be more bothersome to the patient than the benefit that the particular procedure really offers? And that is the question which the Europeans started answering. And then they said that there is no need for you to aggressively chase every CA prostate in the community and eradicate the particular. It is not like a smallpox or a chickenpox where you have to identify them early and then treat them appropriately. Otherwise that becomes a very contagious and mortal disease. No, it is not like that. CA prostate, where the lead time we call, the lead time is about 10 years. The lead time is the time when the malignancy actually starts appearing in the body to the time it starts manifesting. That is the lead time. The lead time is as at least about 10 years at least. That means if the patient develops malignancy today, the probability of one developing a clinically symptomatic disease will actually happen at least 10 years from today. So that is what the lead time. The lead time is so huge that why do you unnecessarily have to identify and chase these particular malignancies and disturb the peace of mind of the particular patient and treat them unnecessarily and subject them to more morbidity and mortality? That is the issue that the Europeans and the Britishers, they all started talking about, and then the Americans started revisiting the real need for. And then there were a few trials which came into vogue, and then they said whether, and then they looked into whether screening is really required, chasing each of these malignancies is really required, and then they also came to a consensus finally that there is no need for you to really chase every malignancy of prostate gland and offer them a curative treatment, because there are so many stages of CA prostate which actually do not need treatment, because patients die of various other reasons than actually succumbing to the disease per se. And that is the reason why we are talking about all these trials today. If you look at this particular data, this data came up in the early 2000s, where this was the data that Americans were talking about. They said that prostate is the #1 killer disease. That is the way they actually projected. And if you see the numbers, overall rate per 1 lakh population, if you see the prostate cancer related illness and mortality, that is actually topping the chart here. And that is why they said that CA prostate has to be such a rampant disease that most of the time it was going unnoticed. And earlier the better that you diagnose these patients and treat them appropriately, so that CA prostate is a curable disease. So that is the sort of a projection that the Western data was giving the early 2000s. And look at this particular data. The same data also suggested that most of these patients actually were above 60 years of age. Majority of the patients were the age group 60 to 80. And that is the time when they said that you will have to take not only the disease factor into consideration, you will also have to take the factor of morbidity and mortality associated with the disease and the treatment per se. That also has to be taken into consideration, so that question was this particular question arose actually. If you have to chase each and every malignancy in the community, is prostate cancer always a life-threatening disease? That is the next thing that they had to audit. In the same study also talked about the mortality associated with. Number one, they said it is the #1 killing disease. And then they said majority of the patients in the elderly age group 60 to 80 had the maximum incidence of CA prostate. The same study also said that you identify these individuals, and these individuals are detected in either autopsy or microscopic prostate cancer. So this found the major 90% of the prostate cancers which are diagnosed were either diagnosed in autopsy, or it was only microscopic prostate cancer at the time the diagnosis was made. That means they were not clinically manifesting enough. The ones that are clinically manifesting were only about 10% of that, 9.5 to the other one, 10%. The remaining 90% of them were either detected at autopsy or were having only microscopic features of prostate cancer with no clinically overt CA prostate manifestations in the patient. And that is the reason why they concluded that there is a gross discrepancy between what is actually prevalent in the community, this 90%, and the one which actually clinically manifests, that is 10%. And then they said, why do you unnecessarily treat this patient? Because if you are going to detect nearly 50% of these individuals in autopsy, that means they have died due to various other reasons, not necessarily due to prostate cancer. And the remaining 42% here, again they have died due to other reasons, but they have been found to harbor malignancy here. It's only a microscopic disease. That means this 90% do not have any clinical manifestations, in which case, what is the real need for us to so aggressively chase this particular disease and offer radical prostatectomy to all these individuals? This is a data from Indian. This is about the earlier ones were about the Western data. Now looking at the Indian data, if you see the Indian Cancer Registry 2011, if you see, then the list of all the malignancies, if you see, do you see prostate cancer anywhere here in this list? You don't see that anywhere at all. That means the prostate cancer, as per the 2011 data, if you see, that did not. That is the reason why we never talked much about CA prostate. But you should also look at the corollary. Only if you look for the disease, you will be able to identify and diagnose the disease. The problem is that we don't aggressively chase with serum PSA in all these individuals, and that's the reason why this clinically insignificant or a microscopic CA prostate were all largely undiagnosed here. And that's the reason why we don't find prostate cancer anywhere here in the list. The next one, if you see, this is Indian Cancer Registry 2021. The 2021, by then serum PSA has become increasingly popular. You can see that it is more common in Assam, Delhi, Bangalore, all the major metropolitan cities have got a higher incidence of. It is not that the disease is particularly prevalent in these communities. It is not like that. The only thing is the diagnostics are much more sophisticated here. The awareness among the individuals is also more here, and people are more educated. They get themselves screened, and that's the reason why you get an increase in incidence in this particular major metropolitan cities here. That's the reason why. That means, what does it mean to you? That means that the more you chase and look for CA prostate, the more prevalent it will be in the community. So that is the bottom line statement. So if you screen more, you are going to get more diseases. But what exactly do you actually need? Do we really need that? or what exactly do you need? That's something which we'll have to address here. So look at this 2011 and 2021, we don't find anything at all here. 2011 does not talk anything about CA prostate. Whereas here, prostate cancer has come as one of the top 10 malignancies in the community. So do you really need to, if you look at this data, both from the Indian statistics as well as the second slide was from Tamil Nadu statistics, both of them have shown that prostate cancer is a significant disease which is prevalent in the community. So this prostate, they finally concluded the Indian Registry 2021, Indian Oncology Group, IOG they call it, Indian Oncology Group, they finally concluded that CA prostate is now emerging as a major health issue. And death from prostate cancer should be avoided. What does it mean to you? That means you have to look for this particular disease in the community, identify them early, treat them appropriately so that death resulting from prostate cancer has to be avoided. That's the second concluding remark of this IOG consensus statement after 2021 and 2022. And majority of the detectable prostate cancers are not symptom, which we concluded earlier on also. And early detection of especially those prostate cancers that cause symptoms and or life-threatening is desirable. Because early detection is a desirable. That is what they had finally concluded here. There were lots of differences of opinion on whom should be screened, whom should not be screened. Lots of differences of opinion in the last 3 decades, from 1990 to 2010, 2 decades for that matter. And then finally 2020 they concluded, 2022 they concluded that it is always preferable to go for early detection of CA prostate. That means that the Indian Oncology Group arrived at a consensus stating that CA prostate has to be aggressively looked for. That means you have to do CA screening with a serum PSA in all these individuals. Now the question arises, who are the individuals who need to be questioned? Do you need to screen the community? That means anybody 45 years and above, you'll have to regularly subject them for serum PSA levels, serum PSA estimation, or who are the target people who have to be screened for? So should all men be screened? That is one question that will arise now. Second question is, who all should be offered screening? What are the inclusion criteria here? Do you need to screen the community, or do you need to screen only select people here? And how should men be screened? What are the modalities by which you'll call them for serum PSA, you'll call them for a digital rectal examination, or you're going to do transrectal ultrasound, or you're going to do an MPMR and all these stages? These are the other issues which need to be looked into. Over the next about 30 minutes or so, I'll be discussing about what is the actual purpose of screening, what is the need for screening. For that, to answer the previous slide questions, you need to know who are the ones, what is the actual purpose of screening, and what are the various methods available to screen, and what are the various contemporary screening trials available, and what are the current guidelines say. The 23-24 guidelines, what does it say? So all this you should know, and finally you should also know where we actually stand as something. So what is the purpose of screening? As I had mentioned earlier, CA prostate is one of the most common cause of death. The second most common cause of death, second only to the lungs and the bronchus. CA prostate has become one of the very common causes for death of an individual. That does not mean that all patients with CA prostate eventually succumb to the disease. They are not that at all. If you take 100 men who die, CA prostate ranks as one of the second common cause of cancer-related mortality. Not all mortality in general. So cancer-related mortality, CA prostate ranks the second most common cause, cancer-related mortality. But if you take 100 CA prostates, one or two eventually succumb to the disease. Not all of them succumb to the disease. The corollary also you should understand. If you take 100 cancer-related deaths, more of them are due to CA prostate. But if you take 100 CA prostates, not all of them eventually succumb to the disease. That distinction you should be able to make. And 5-year survival, if you see here, 5-year survival for localized and for regional node involvement, if you see, 5-year survival is as high as 100%. In CA prostate, whether you treat them or not, they are going to live for 100 years. Patients with localized or organ confined CA, if you are not going to treat them at all, they are going to live for 100 years. That is what the data show. And patients with the regional node involvement, again they are going to live for another 5 years. That means CA prostate is such a slow growing disease that it does not cause mortality that easily. So that if you, on the other hand, if you take distal metastasis, then the probability 5-year survival is very less here. Okay, so that distinction also you should be able to make. So there is methods of screening as we commonly do is a digital rectal examination. That has also become very controversial now. People have started now questioning whether there is really a need for digital examination. But for a postgraduate point of view, for an exam point of view, always never ever miss out a digital examination. As Bailey Love says, no, you don't put your finger into the rectum, you put your, you don't put your finger into the rectum, you put your mouth into it. Bailey Love, our Bailey Love 21st edition, that Bailey Love had actually mentioned that one of the footnote for CA prostate evaluation. Okay. So that is what it is. So serum PSA is again another screening modality which we commonly use these days. Okay. So digital examination and the serum PSA. Now looking at the serum PSA, if you look at the serum PSA levels of more than 10, 2/3 of them will have malignancy. If you look at the PSA of between 4 and 10, 1/3 to 1/5 of them will have malignancy. 2/3 of them above serum PSA of 10, and 20 to 30% of them with serum PSA 4 to 10 harbor malignancy. That does not mean that less than 4 is normal. Though for all practical purposes we say serum PSA of less than 4 is for all practical purposes considered normal. Serum PSA of less than 4 only indicates that aggressive chasing further is not required. That's all it says. On the other hand, if you audit the number of CA prostates that are there, the PSA level of 4 and below, if you see, the earlier slide I said less than 4 is normal, but here I am saying that even if it is less than 4, PSA level of 3 to 4, 3.1 to 4, there is a 26% chance that there may be a malignancy. If you take 100 patients with serum PSA of 31 to 40, 1/4 of them will have, 1 in 4 will have malignancy. Same way between serum PSA of 2.1 to 3, again nearly 22% of them, 24% of them have malignancy. That means serum PSA of 2 to 4, if you see, 50% of them will have malignancy. That is the reason why there are many authors, many studies which have actually brought down the cutoff to 2.5 now. You understand? There are many studies, though for conventional purposes we still have the cutoff value as 4. For all practical purposes, though we have 4 as the cutoff here, there are many studies which have actually included the cutoff, have set the limit as 2.5. That means anybody with the PSA of 2.5 and above, there is a 50% chance that there can be an occult malignancy. So they have brought down the cutoff to 2.5. So any PSA which is more than 2.5 has to be looked into a little seriously. This is one data. If you look at the other data, if you see that, this is a very interesting article published in New England Journal of Medicine. I'm sure all of you should go through these articles, which are historically important these days, but will greatly help you to understand the evolution of treatment for CA prostate. This which came in 2004, that is a time when CA prostate was so rampantly being diagnosed. Every issue in Journal of Urology had loads and loads of articles related to CA prostate. So that is the time when this particular data came. This is a European data which was published in New England Journal of Medicine. So what do you understand from this data shown here? What do you understand here? See this particular slide here. 93 men will have CA prostate died for over 10 years. If you screen them, if you take 1,000 men from general population who are 55 to 70 years of age and screen them with PSA levels, you will identify that and follow them up also. 93 of them out of 1,000, that means 9 to 10% of them will develop CA prostate over 10 years. That is what this data shows. So if you look at this particular data, you will understand that there is a very high prevalence of CA prostate in the community, because 10% of population range from 50 to 60, 50 to 70, 55 to 70 have malignancy. That is what this particular data shows. On the other hand, if you follow them further and see whether they eventually succumb to the disease, you will realize that only 3 of them will actually die from the disease. cancer specific mortality is only in 3%. That means the overall percentage is 0.3. Overall prevalence of cancer specific mortality in this age group is 0.3. 3 out of 1000 is 0. How much is it? 0.003, yeah? 003. That's what this. See, 3 out of 100 is 3%. 3 out of 1000 is 0.3%. 0.3%. Okay, that's what it shows. On the other hand, you see that 50,000 men aged 55 to 69 who had no PSA screening. That is the data which showed PSA screening. 1,000 men who are screened with PSA, 1,000 men who are not screened with PSA, and they were followed up. And then they found that there it was 93 men who developed CA prostate. Here is 55 men. So there is a 50% reduction in the number of patients diagnosed to have CA prostate if you don't screen. There are 93 to 55. Nearly 40-45% reductions in the numbers. That means higher the numbers detected if you do a screening. That is the data you have, you arrive at based on this. Whereas this data you see, 4 men will die from CA prostate over 10 years if you don't screen. If you screen, how many of them die? 3. There it is 3. If you screen, it is 3 who die of the disease. There is cancer specific mortality in screened group is 3, whereas cancer specific mortality in unscreened group is 4. There is no difference at all between the two. So, whether you screen or not, it is immaterial. Only thing is, by knowing that one harbors a malignancy, it is only going to put some huge psychological pressure on the patient, and he is going to die of various other reasons, psychosomatic disease also. He is not going to eventually die from the disease. In which case, why do you unnecessarily treat them all with radical prostatectomy and radical radiotherapy? So that is the issue which these people are also. Europeans, when the Americans are so rampantly doing radical prostatectomy all over the place, the Europeans started questioning that move of unnecessary radical prostatectomy being done. So this is the reason why you should, this is what will be the final take-home message from this particular talk. See, the number needed to treat, the number needed to screen, then the number needed to treat. The number needed to screen is to identify this one particular person to be having malignancy. You have to unnecessarily screen so many of them. So the number needed to screen, to make a diagnosis in one individual, you have to screen so many of them. So the number needed to screen is very high. Ultimately, you need to weigh the benefits and the risks of any particular screening or any particular procedure that offers and see what outweighs what. Ultimately, if the risks outweigh the benefits, then it is of no use in doing that particular screening method at all. I will quickly run through a few of these. I will come back to the slide later. There are 2 screening trials which you should know. One is an American trial, one is a European trial. The American trial is PLCO, prostate, lung, colon, ovarian malignancy trial, PLCO trial. The other is again another. This is an American trial, this is a European trial. These 2 trials are excellent landmark trials which talk about the need or no need for screening for CA prostate. All of you should know these 2 trials by heart. How many are recruited? 75,000 people. Here nearly 2 lakh people are recruited. Age group is also very well defined here, 55 to 75, 55 to 70. Properly randomized into those who are screened, not screened. Everything is being done perfect. Sample size is adequate, the study design is good, perfect randomization, they follow for 10 years. 10 years follow. So what does the final data show? Both of them? Both the screening trials concluded that death rate from prostate cancer was very low, which we talked about earlier. Patients dying of cancer prostate is only 3 in screening group, 4 in non-screening group out of 1,000 people. That means the death from prostate cancer is very low and did not significantly differ between the 2 groups, screened or non-screened, unscreened, it hardly made a difference. That's the reason why both of them concluded that there is no real need for you to aggressively screen the general population. If you look further audit, I think there is not much of time we have, so I think I'll run through these slides. You should go back and read each of these. PLCO and ERSPC, all of you should know by heart. Because there is something which older examiners will be interested because they have gone to older examiners for 55 years and above. definitely would have been in practice for at least 25 years. And I'm sure they would have all gone through what happened in the early 2000s and late 1990s. So late 1990s, how this was marketed, and then early 2000s, how it was so rampant, and late 2000s when they started questioning, and then the 2010 to 2020 they started reducing the number of cases of radical prostatectomy being done. They would have seen the whole, they would have gone through the entire timeline of all this management of CA prostate. So they will be interested now a little more about this screening trials, PLCO trial, and here these two are so popular. One is United States, one is from Europe. If you look at the increased chance of diagnosing prostate cancer with the screening, American trial said 17% increased chance of diagnosing, not preventing mortality, making a diagnosis. Whereas they say 40% chance of 40% increase in the number of cases being diagnosed. But final outcome, you diagnose more patients. What is the ultimate outcome? Ultimate outcome, there is no significant difference in the cancer-specific mortality at all. And then looking at the number of problem with the American trial is that nearly 70% of them were earlier screened with serum PSA. That is because the protocol was not so stringent here. They said, look at this particular randomization. So they said one group had serum PSA and DRE done, one group did not have the screening done, and the follow-up protocol, how long to follow up, how frequently to follow up, everything was left to the individual. There they have this GP system, no? The local doctor will treat them first before they go to a specialty doctor. So they left it to the local doctor, the first level physicians, primary care physicians, to take a call on how frequently to follow up. Whereas here it was much more organized here. They had a protocol. Europeans always had a proper game plan in mind. Americans never had one game plan at all. So the Europeans were able to call them on periodic. We'll talk about that, how stringent the particular evaluation is when we talk about active surveillance. So they had a proper method of screening. So this was much more organized. So you have to actually accept the European trial and the American trial, you have to accept with a pinch of salt. So this is what it means. So the contamination that means the contamination is nearly 70% already been screened. So contamination percentage, if you see, that is as high as more than 50%. That means 50% of them either were known not to have a high PSA earlier, or they were known not to harbor malignancy when they were enrolled in the trial. Either they had a screening PSA done, or digital examination, or a biopsy. 50% contamination. So they knew 50% of them knew what they are actually. In spite of knowing that they do not harbor malignancy, they have recruited themselves in trial. This is a fallacy. This I was talking about number needed to screen and number needed to treat here. So look at this. Look at the cumulative number of deaths that happen in patients who are screened, and look at the number of years followed. So see here, up to 10 years follow-up, both the screening as well as the control, they both go parallel to each other. You cannot say that screening is better than the control at 10 years of follow-up. Both go simultaneously. So same way, here also up to 8, 9, 10 years, there is not much of that. After 10 years, the gap widens between the control group, between the screening group. The screening group and the control group, the gap widens beyond. So up to 10 years, there is not much of difference at all. So if a person is going to live for 10 years from the time the diagnosis is made, what more can you ask for? So and they concluded that the number needed to treat is 48. That means to get benefit with radical prostatectomy or radical radiotherapy, to offer a significant benefit to one individual, they have to treat 48 patients unnecessarily. That means the remaining 47 were subjected for unnecessary morbidity related to or mortality related to the procedure, radiotherapy or radical prostatectomy for example. So the number needed to treat is very high here. NNS we already talked about, number needed to screen is very high. So number needed to treat in radical prostatectomy is also very high here. So if you screen the patients and offer treatment based on your screening, that means you are over treating 47 patients unnecessarily. 47 means 94, 50, okay, 94% of them unnecessarily treating. That is what it means. So finally, this US Preventive Services Task Force, they looked at both the data from European ESRPC and the PLCO, and then they concluded that there is only a level 4 evidence to suggest that screening should be done in all individuals. And then they put an end they clearly, maybe the late 2010 or 2011 or 12, I think that is the time when this particular the US PSTF consensus guidelines came up, maybe 2010 or 11 or 12, that period only. After all the PSU and ESRPC trial results came out, no? Then they realized that we are actually over-investigating and over-treating these individuals. And then they came up with the guidelines where they categorically said that there is only a level 4 evidence to treat all these individuals based on their screening. And recommended against screening for prostate cancer with CRPS. Then don't screen all of them unnecessarily, because you are going to make over-diagnosis. And once you make a diagnosis, what will it will end up in surgery, which is unnecessary here. Because number needed to treat is 48. To offer benefit to one individual, you are going to do radical prostatectomy in 47 other individuals. Unnecessary. And no net benefit. And harms largely outweigh the benefits that that particular screening offers. Okay? So that is what they concluded. Okay. And then they said, if at all you have a doubt, do various types of markers you can do to see if these patients really need to be further evaluated and offer treatment, which you can read about it. So what are the AU guidelines of 2019 said? Less than 40 years of age, routine screening is not recommended. Anybody less than 40 years, please don't do it. Unless or whether they have some strong other history related to CA prostate. 40 to 55 does not recommend routine screening. Up to 55 years of age, they do not recommend screening at all, unless really warranted. 55 to 70 years of age, decision revolves around the benefits of preventing, say, prostate cancer mortality. If there are certain identified to be having high risk factors, then you can evaluate these individuals and treat them appropriately. That means up to 55 years of age, routine screening is conducted. And they preferred biennial screening. That means once in 2 years. Don't do it every year, don't do it every month, don't do it once in 3 months, do it every alternate year. That is enough, they said that. And no routine screening. They said up to 55 years, no routine screening. 70 years and above also no routine screening. 70 years and above, where the life expectancy is less than 10 years, no need to unnecessarily screen them with serum PSA and disturb their peace of mind. That is what the consensus was in 2019. The same thing more or less echoed by European guidelines also. They said 45 years, they said 45 years. Unless there is a strong family history or African Americans, specific group, ethnic group, African Americans, if at all the PSA is being done, and if the PSA is more than 1 nanogram at 40 years of age, or 2 nanograms at 60 years of age, the cutoff they say is 2 here. Because between 2 and 4, there is a 50% chance that there may be malignancy. So they said there is no way, unless the patient falls in this particular category, the routine screening with the serum PSA is not recommended here. This is the differences between, okay. Then finally the 2023 guidelines. The 2023 guidelines say that you can start evaluating them a little earlier also if you really feel that it is warranted. 2023, earlier they said up to 55 years routine screening is not required, they said. Whereas 40 to 50 years of age, you can start evaluating them if they are at average or a high risk individual. If there is a strong family history, or if they are African Americans, or if they have been earlier evaluated PSA found to have 1 or 2 nanograms per ml at that particular age, then they can do further follow-up with serial PSA monitoring. Otherwise, old rule applies. Old rule is up to 55 years, no recommendation at all. That is what it means. And initially, every 2 years they said that 2019 guidelines, 2023 they say, not necessary to do it every 2 years. If in case in 2 years everything is normal, why do you want to do it in the next 2 years again? You can postpone it to 4 years. So between 2 to 4 years you can. So DRE was optional earlier, mandatory even earlier. 1990 and 2000, DRE was mandatory. And then in 2019 they made it optional. And 2023 they have categorically mentioned that DRE has got no role to play in primary screening. Because there are so many malignancies which will have a normal DRE finding. There are so many normal prostates which will have an abnormal DRE finding. So DRE per se is actually not the screening method. That is the current consensus, but don't stick on to that consensus. You should all do DRE. In your exam, you can never say no 2023 guidance, say no to DRE, so I have not done DRE. You cannot, for your exam point of view, forget this particular thing. You take only this 2019 data. Not optional, it's mandatory. Okay? Then briefly about the active surveillance. Active surveillance, what is the difference between active surveillance and watchful waiting? Active surveillance is both are not doing anything at all. You make a diagnosis of CA present but don't do anything at all. In active surveillance, what do? You don't do anything at all. But if in case the patient gets upstaged, or if in case he needs a treatment, you plan for a treatment with curative intent. That is active surveillance. Whereas in watchful waiting, if at all this gets upstaged, they are going to give only a pilot data, not going to treat the patient with curative intent. So that's the basic difference between watchful waiting and active surveillance. In active surveillance, we always put the patient on a regular monitoring with an intention to cure the disease if in case it escalates further. Whereas in watchful waiting, you keep the patient on regular follow-up, but you will not aim at cure if in case it upstages. You will only give palliative care. That's the basic difference between the two. This is one study, Prayas study. They're very, very popular. It's a Dutch prostate cancer research international active surveillance Prayas study. This is a Dutch study based from Netherlands. It's a European study basically. It was one of the studies which had a much more organized protocol. The inclusion and exclusion criteria were very well defined. This is the one which actually revolutionized the treatment of CF prostate. Earlier, all these patients were subjected for radical prostatectomy. Histologically proven adenocarcinoma. If it is histologically proven, they were offered radical prostatectomy. Men should be fit for curative treatment, they were offered radical prostatectomy. PSA level, whatever it is more than 4, they were offered. PSA density, which is high, offered. Any clinical stage, they were offered. Any Gleason score, they were offered. Even 2 plus, those days, they were offered. They were also being scored 2 plus 2, 1 plus 3 and all, they were being. All that was, once you make a diagnosis of adenocarcinoma, they were all knocked off. But here, in active surveillance, they said that the patient with the PSA level less than 10, or if it's a clinically T1C or a T2 lesion, T2 is organ confined lesion. If it is an organ confined lesion, the role for active surveillance is also there. Please remember, the treatment of choice may be radical prostatectomy, but active surveillance also has got a significant role to play. That is what the Prayas study said. And a Gleason's grade of 3 plus 3, there is no real need for you to always go for radical. Nobody questioning if you offer radical prostatectomy. But there is no real need for you to go for radical prostatectomy every time you make a diagnosis of 3 plus 3. If you feel that this candidate has got only 1 or 2 biopsy codes which are invaded, or if you feel that the patient is willing to come for a regular follow-up, you can might as well put them on an active surveillance and be done with it. So how active surveillance is going to be? This is how it is going to be. Such an organized, structured protocol for 7 years. Once a diagnosis is made, you follow them up for 7 years again. Start from 0, 3, 6, 9 months and 12 months, 15 months, 18, 21, 24, 30, up to 84 months like this. And do you expect the patients to come back to you for every time for PSA testing like this? Every time in real break, is it possible? In Indian scenario, is it possible? Extremely difficult. Possible, but extremely difficult for you to adhere to those norms. Sometimes there will be some dropouts. Sometimes they will get referred. They themselves will go to somebody, some other doctor who will violate this particular protocol. European study, it's not possible. They have got such a family structured, organized networking that once the patient is recruited in the study, no other general practitioner will take them up for any further treatment. So they will always be referred back to the primary care physician. So once the patient comes back to you again, they will be re-recruited to the study. Whereas here, if you see DRE being done so frequently, but that is the time when DRE was mandatory. Okay, and the biopsy was done so few. In 7 years, they have done it 4 times. Every alternate year, they are doing biopsy to see if it is only 3 plus 3 or whether it is upstage to 3 plus 4. If it gets upstage to 3 plus 4, they are not candidates for active surveillance anymore. Problems with active surveillance is that, see, a patient is made a diagnosis. Now the patient is diagnosed to have CF prostate. Will the patient accept If you tell them that, say, hey, you have a malignancy, that malignancy will grow in your body slowly. I am not going to do anything for you at this point. I am only going to observe you. Which patient will accept you, tell me? Extremely difficult for one to accept the fact that he harbors malignancy, but nothing is being done for that. You understand? That's a major challenge that you have to answer. So does a delayed treatment reduce the chance of cure? You are not doing anything now. 7 years being followed up. 7th year it becomes 4 plus 5. Who is to be blamed for this? The patient will immediately ask the treating physician, you did not do anything when it was 3 plus 3. Now my PSA is 40 and the grade is 4 plus 5. And now you say surgery cannot be done. When surgery could be done, you did not do it. When you want to do surgery, you say surgery could not be done. It's extremely difficult situation that you put yourself in as a treating physician if you offer active surgery. This is a major question which you have to answer. Does delayed treatment reduce the chance of cure? The patient is in a vital period of window of curability that is lost by you sitting on me all the time. 7 years I was coming to you regularly, listening to whatever you said. Suddenly it has gone from 3 plus 3 to 4 plus 5 now. Who is answerable for that in the court of law? That's something which will have to be, it's a very tricky question. So it is very unclear on what the data shows. If you look at the John Hopkins data, they say that the delay does not compromise the curability. That's what John Hopkins data says. Whereas the other data, the Toronto, the Canadian data says that about 58% of them, when they underwent radical prostatectomy, subsequently had an upstaging to T3A to T3C. What does that mean to you? Which you originally thought is only a T2, actually is T3A. You understand? Then the patient will again ask you, why did you not do it in the initial setting itself? When it would actually be in a T2 disease. Very difficult for you to give a substantial reply to this particular accusation. So it is not clear whether the delayed treatment will really reduce the chance of cure or not. And that is what the Americans were cashing in on. They said that all these questions need not be answered if you operate and then knock it off in one go. You understand? That is what the Americans were doing. Can you predict the progression in active surveillance? So today it is 3 plus 3. What is the guarantee that it will not become 3 plus 4 or 4 plus 3 tomorrow? Can you predict the progression? Extremely difficult to answer this particular question again, because it is not very clear. Because there is not one variable which plays a role. The PSA level, the PSA kinetics, the density, the number of course positivity, all these are the other features which will play a major role in deciding whether it is going to progress further or not. And third one, how do the patients tolerate it? As I mentioned earlier, if you won't tell the patient, see, I've got a malignancy, but I'm not going to do anything on you, I'm just going to sit and watch whether you're going to progress further in the disease or not. Which patient will accept? That is going to produce so much of psychosomatic trauma to the patient that constantly the patient will be thinking about the malignancy that he is harboring, and finally what will happen, he will become a mentally unstable person. The anxiety and depression will have a severe toll on his body and performance. And that is something which we have to, so many variable data, you have serum data says nothing will happen to them. Then there is a Burnett data which will say something will happen to them. Pickles finally said that if you take care of the psychosocial barriers, like properly communicating to them and educating them about the disease and all, nothing will happen, because each one will say one thing, but it is ultimately the individual who has to decide whether he will be able to put up with all this mental trauma or not. Only then you have to subject him for the procedure for active surveillance. How safe it is, I was talking about the vital period of window of curability. What will happen if it becomes 4 plus 5 suddenly? You will expect 3 plus 3 to become 3 plus 4 or 4 plus 3 only. Suddenly if it becomes 4 plus 4 or 4 plus 5. Who is responsible for that? How safe it is? There are again various trials which talk about the pros and cons, STAR trial, the pivot trial, NICE guidelines. All these talk about nothing will happen, don't worry. But ultimately it is the patient who is affected. It's very easy from across the table to say that no, nothing will happen. But it is the patient who goes through all this mental trauma. He has to take a final call on what he wants to. So it will ultimately be a collective decision. Active surveillance is not an easy job. You may say, I will not do anything. You may call him again and again and again for periodic follow-up. But every time to come to the hospital to get a biopsy being done, every time to get a blood blood test being done, not an easy thing for the patient. And that if he has to do for 7 long years, like in prior study, do you think it will be easy for the patient to go through all this emotional, mental agony? Not possible. Most of the time there will be a dropout. To summarize, see, active surveillance is a good option. Patient should be informed of all the uncertainties. Discuss with the patient and take shared decision. That's very important. It is always important that you take a shared decision making. It should always be a collective responsibility. It should never be a unilateral one. You should always talk to the patient, tell the patient the pros and cons of each of the procedures. Radical prostatectomy, what are the advantages and demerits? Active surveillance, what are the merits and demerits? Radiotherapy, what are the possibilities one can have? Okay, all the pros and cons of each of these, you have to talk to the patient. And then once the patient is convinced with active surveillance, then you can recruit them for your Then I will give you one summary of various trials. Please go, I'll just run through in 5 minutes. But very important for you to note down also, because there are so hundreds and hundreds of trials in CA prostate. It's impossible for you to know each and everything. But for each of these types of CA prostates, there are a few landmark trials which you should know. All these trials you should know. Screening, as I had mentioned earlier, European trial and the American trial. ESRPC trial, European standard randomized study for screening CA prostate, PLC prostate, lung, colorectal, ovarian screening trial. These two trials you should know. Merits and demerits of screening trials you should know. Then for screening, chemo prevention trials. There are chemo prevention trials. Prostate cancer prevention trial. They only talked about the role of finasteride. The finasteride is supposed to reduce the microvascular density of the prostate gland. So if the microvascular density reduces, the angiogenesis also comes down. Angiogenesis comes down, apoptosis increases. Thereby the cells shrink, die, and the patient, you can aim at shrinkage of the gland. So that is what the finasteride study or PCPD, prostate cancer prevention trial. They said that if you give the patient finasteride for a longer period of time, that itself will delay the onset or progression of malignancy. That is what PCPD trial is. Reduced rate, the same thing, instead of finasteride, they used dutasteride. And then they said finasteride compliance is poor because they have to give it twice a day. Dutasteride has got a longer half-life, you can just give it once a day, it's enough. And select triad, the other chemo, vitamin E, selenium and all that. Just read about all these trials. So if they ask you about chemo prevention trials, these are 3 landmark trials which you should know. Regular screening trial, PLCU and ESRPC. European trial, American trial. Here it is PCPD, reduce and select trials for chemo prevention trials. Then for locally advanced prostate cancers, it is local but advanced. That means it is not just beyond the confines of it, but not become metastatic. What? There are various trials. Pivot trial you should know. SPCG trial and pivot and protect, at least you should know. Pivot trial is prostate cancer intervention versus observation trial. Intervention versus observation. You do something, you don't do anything at all. Do something as radical prostatectomy. Don't do anything at all with observation. Active surveillance. You have a presence grade of 3+3, PSA of 8. What will you do? You are not doing anything at all. Observation trial. Do radical prostatectomy. That is the pivot comparison between doing something and not doing anything at all. That's a pivot trial. Then SPCG trial, Scandinavian prostate cancer trial. They showed a survival benefit for radical prostatectomy against watchful waiting in clinically detected localized prostate cancer. In localized prostate cancer, if you are going to offer the patient radical prostatectomy, it becomes active surveillance. If you say that, no, I'm going to watch you, but I'm not going to do anything at all, if at all you develop upstaging or disease, maybe I'll do some sort of a palliative treatment. That becomes watchful waiting. So this Scandinavian trial compares survival benefits of radical prostatectomy versus watchful waiting. And definitely radical prostatectomy scores over watchful waiting. The third is a protected trial, prostate testing for cancer treatment, where they had 3 arms here: radical prostatectomy arm, radiotherapy arm, and active surveillance arm. They followed up all these patients. The second trial, the cancer specific mortality was the same in all 3, which we discussed earlier also. Whereas patients in active surveillance group had increased incidence of metastasis. But do they die of the disease? That becomes common for all 3 arms. Radical prostatectomy arm, radical radiotherapy arm, and the active not doing anything at all, active surveillance arm. All 3 will have same cancer specific mortality, but the incidence of metastasis is relatively higher in active surveillance group. And then you have hormone sensitive prostate cancer, which is metastatic. Initially we had a localized prostate, localized and locally advanced prostate cancer. Now we have a hormone sensitive metastatic prostate cancer. Metastatic hormone sensitive prostate cancer. We have charted trial we discussed last week. Charted, Stampede and Latitude trial. We talk about the benefits of docetaxel, benefit of androgen deprivation therapy with abiraterone. Read about all this. All these trials you should know. In detail you should know. Further slides will have detailed description of what Charted is, what Stampede is, what Latitude is. And may not have time, but go through all of that. Okay. And then for same thing metastatic, instead of hormone sensitive, it becomes castration resistant prostate cancer. You have affirmed trial where you can give enzalutamide or enzalutamide, other chemotherapy drugs, olaparib, whatever it is. Read about all these trials. Just at least the names, certain names you should know. One or two at least you should know. At least affirm you should know. Affirm is the one which we use these days, enzalutamide or prevail. Olaparib we don't use much, so these two at least you should know. Enzalutamide trials you should know for hormone resistant prostate cancer. For hormone sensitive, we have docetaxel, abiraterone, prednisolone. Whereas the hormone resistant, you have enzalutamide, olaparib. Find out what it is. Okay. And then non-metastatic but castration resistant, you have abiraterone. Read about it. And then, what is the PROMISE trial? What is the precision trial? When you want to evaluate CA prostate, which one will you do? Will you do a transrectal ultrasound or will you do an MPMRA? That's again another very commonly asked question. You should have a proper understanding of that. MPMRA you will do only if you are not doing a biopsy. I will do an MPMRA, then I will do irrespective of whatever it is, I will do a transrectal. Then there is no meaning in doing it. MPMRA is not done to do a local staging. If you want to do a local staging of CA prostate, it should be endorectal MRA or transrectal ultrasound. MPMRA will not give you a local staging. Please understand. MPMRA is only useful when you are not sure whether you are going to be malignant or not and the patient is not willing for a biopsy. In which case you can do MPMRA and see whether it pyrites fall whether 1 to 2 range or 3 to 4, 5 range. And then decide on biopsy. And if you are going to do a biopsy, whether you are going to do a transrectal ultrasound biopsy or fusion biopsy with targeted fusion biopsy, MRA targeted fusion biopsy. If you use this and that and then take biopsy for representative data using MRA. So that is what is PROMISE trial and precision trial. PROMISE trial, what does it say? Assessing the accuracy of MPMRA versus transrectal biopsy. And precision trial is MPMRA targeted biopsy with standard transrectal biopsy, 2 arms. MRA was found to be superior to standard transrectal biopsy for detection of clinical symptoms. That's the bottom line in both PROMISE and precision. In summary of all this. Okay, that's it. Thank you.